Well, burn injury is going to serve as the setting of these studies. Burn injury initiates a series of metabolic responses immediately and most prominently the systemic inflammatory response. And this occurs due to destruction of the skin barrier to microorganisms, invasion of the bloodstream by these microorganisms, set up a robust cytokine response, especially for interleukins IL-6, which is 100-fold elevated in the serum by 2 weeks post-burn, and IL-1 beta, which is 3-fold elevated above normal by 2 weeks post-burn. And also the stress response. This involves the sustained release of endogenous glucocorticoids and catecholamines, which may remain elevated for between 6 months and a year following the burn. These two responses initiate a hypermetabolic condition, resulting in skeletal muscle catabolism and resorptive bone loss, both occurring starting on the first day post-burn. Now, in this slide, you can see the elevated adrenal gland generation of glucocorticoids anywhere between 3 and 8 times the upper limit of normal, depending on which lab values you take as the upper limit of normal, usually between 50 and 125 micrograms per day. And so these were from 2 separate publications about 10 years apart. This slide shows the photomicrographs of 2 iliac crests, a normal one in panel A on the left and one from a burn-injured person in panel B on the right. Note in panel A, the cells lining the bone surface, which you can see over here following the arrow, they're osteoblasts. These are bone-forming cells. They synthesize type 1 collagen that eventually forms a crystal with calcium and phosphate to form the bone mineral. On what you see here on panel B, in the burn-injured person, is a lack of osteoblasts at the bone surface. In this slide, another way of showing normal bone formation is to administer 2 doses of the antibiotic tetracycline. The tetracycline labels the newly mineralized bone surface, and measurement of the distance between the bands and the time interval between doses gives you what we call the mineral apposition rate, which when multiplied by the length of surface taking up the tetracycline gives you a rate of bone formation. This slide shows a normal rate of bone formation in an unburned adult. In contrast, this slide shows the tetracycline labeling in a burn victim. Note that the double label has disappeared and single label surface uptake is patchy at best, indicating reduced bone formation. This slide shows an iliac crest in a sheep model of burn injury. The top panel shows the appearance of scalloping or chewing out of the bone surface. And this is histologically visible at 5 days following the burn. However, biochemically, resorption starts on day 1 with an elevation of the biomarker C-telopeptide of type 1 collagen, a measurable breakdown product that can be analyzed in urine and blood. In an attempt to stop the resorptive bone loss, we recruited pediatric burn patients for a randomized, placebo-controlled, double-blind trial of an anti-resorptive agent, in this case a bisphosphonate named famidronate. It, or a placebo, was administered within the first 10 days of burn injury when resorption was the most active. In this slide, you can see that those who received the bisphosphonate, shown here in the black bars, uh, continued to accrue bone for the first through the 24-month study period. Those who received the placebo in the white bars lagged behind until 24 months, when in fact the placebo group spontaneously recovered. So this was a change in total body bone mineral content, and this was in fact this incorporates both cortical bone, which is 80% of total body bone, and trabecular bone, which you'll see on the next slide is metabolically active bone. So in contrast to total body bone mineral content, when you look at the trabecular bone, which is metabolically active bone, and we look at that, which it's concentrated mainly in lumbar spine. When you look at that, and this is done with dual energy X-ray absorptiometry, then we see that after 24 months, those receiving the placebo could still not catch up to those who received the bisphosphonate. And at the end of the 24 months, the age-related Z-scores for bone mineral density, again using this dual energy X-ray absorptiometry, showed that with the pomidronate treated patients, their bone density Z-score for age was normal, but it was still low in the placebo group. So in 2013, the Shriners Hospital, which was where all the burn patients were cared for, had revealed a database for their muscle protein balance studies in burn patients. 17 children who participated in the randomized controlled trial of pomidronate also had been consented to undergo muscle protein kinetic studies using a stable isotope of phenylalanine. We examined muscle protein breakdown and muscle protein balance in those patients, excuse me, who received pomidronate and those who received placebo. So the key findings from these muscle protein kinetic data were shown on this slide. The rate of muscle protein breakdown, which is shown here on the y-axis, is considerably reduced in the burn patients who received the pomidronate treatment compared to those who received the placebo. And the result of that was the net balance, which we normally find in burn patients as negative, all of a sudden becomes positive. So we had an agent that perhaps was an anabolic agent. So to corroborate these findings, we measured muscle fiber diameter in specimens from burn patients at the same period post-burn, 30 days. And these specimens had not been included in the stable isotope studies. And as this slide shows, we found that the muscle fiber diameter, which is an index for strength, is higher significantly in the pomidronate treated patients than in the controls. So these subjects who had preservation of bone mass with pamidronate had net positive muscle protein balance at 30 days post-burn, compared to those with placebo who had negative protein balance. These data had been corroborated by measuring muscle fiber diameter in both groups of subjects, with those receiving pamidronate having a significantly higher fiber diameter. The results of the following cell culture experiments were obtained in Dr. Linda Bonewald's lab at Indiana University, specifically by Fabrizio Pin, Andrea Bonetto, who were in the Department of Surgery. Linda oversaw the experimental part of this study, which utilized mouse myoblasts, C2, C12 myoblasts in culture, with serum from normal children, those who received pamidronate, and those who received placebo. So this slide shows, we're going to use, this is a 5% serum, this is 1% serum. This slide shows the results of myotube size after culture of these mouse myoblasts with serum from normal children in green, burn patients receiving placebo in red, and burn children receiving pamidronate in blue. And as you can see, the myotube size was reduced in the burn patients receiving placebo, but that size was significantly rescued in the burn patients receiving, serum from burn patients receiving pamidronate. Now in this slide, focus your attention on the lower left, panel C. This is looking at the amount of ubiquitin, which is a component of the ubiquitin ligase catabolic pathway in myoblasts. And this shows that while ubiquitin levels are elevated in the cultures from burn patients receiving placebo, they're significantly reduced in the cultures with serum from bisphosphonate treated patients. In contrast, phosphorylation of components of the anabolic pathway in myoblasts, AKT and mTOR, was increased in cultures that were treated or with serum with this from bisphosphonate treated patients in both cases, whereas they had been suppressed in cultures from burn patients with serum treated with placebo. Now, when these cell culture experiments were repeated, only with the addition of anti-TGF-beta antibody, what you see is that the magnitude of myotube size in the burn patient, in the cultures from burn patients who had received placebo, this now increased to a point of comparability with myotube size from the burn patients who received pamidronate. And on top of that, when the anti-TGF-beta antibody was added to the cultures with myoblasts with serum containing with bisphosphonate treated serum, you can see that there was virtually no difference. So that the most prominent change was here in the placebo group, where pamidronate, where the TGF-beta antibody promoted rescue of the myotube size comparable to the bisphosphonate treatments. So to summarize, burn injury will cause inflammatory and stress-related responses that will cause an increase in bone resorption, a release from bone of TGF-beta, and an increase in muscle wasting. Whereas an anti-resorptive agent, imidronate, will block the bone resorption, decrease the amount of TGF-beta released from bone, and preserve muscle mass. So the data obtained in these experiments supported the original findings of a bisphosphonate preserving muscle mass. Now we understand the mechanism to be an inhibition of release of TGF-beta from bone by means of inflammation-induced bone resorption. Interestingly, this mechanism was first described by Waning et al. In Nature Medicine in 2015. And in this study, patients with breast cancer bony metastases developed muscle cachexia by inflammation-induced resorption secondary to bony metastases. TGF-beta was released from the bone and caused disruption of the ryanodine receptor in muscle with consequent calcium leak and muscle wasting. Given that TGF-beta release from bone affecting muscle metabolism is shown in two discrete groups of patients, this mechanism may be fundamental and play a role in mutual regulation of muscle and bone mass. It also points to potential role of bisphosphonates in the preservation of muscle mass and a variety of other conditions, hyperresorptive conditions, yet to be studied. So that's all I have. Thank you very much.